Behavioral Health Commission Subcommittee on Workforce. Chairs were chosen just within these last month or so. And so Katie Adams of Southwestern Community Mental Health Center and myself, Carrie Cadwell of Fork County, are co-chairing this particular subcommittee and being assisted by DMHA staff, Jocelyn, which I appreciate all the help Jocelyn has given me trying to get some things organized for today, even if they were, just some small logistics. So I wonder if it is that we could just go around real quick, and that's always a super fun process when you're on Zoom, as to who's going to talk first, just to do quick introductions, and then basically your current role. So I'll just, I'll start off and point to Rick. Rick, why don't you start the group?
Hi, I'm Rick Crawley. I'm actually filling in for Matt Brooks while the position is vacant, and have been in the business for a long time and looking forward to today's meeting. Thank you.
You just want us to be aggressive?
Be aggressive, please.
All right, I'm Steve McCaffrey. I'm the CEO of Mental Health America of Indiana, and I am a member of the Behavioral Health Commission.
Good morning, I'm Katrina Norris, and I'm the director for the Indiana State Psychiatric Hospital Network.
I'm Rachel Halleck. I'm the Deputy Director and Chief of Staff of the Division of Mental Health and Addiction.
Good morning, I'm Zoe Franz, and I'm the Chief Strategy Officer at Valley Oaks Health and have been in community mental health now for about 3 years, but in behavioral health, primarily in the for-profit setting, for about 20 years, and know a lot of you well. I feel like I'm the rose in between two thorns with Rick and Steve, who have both mentored and have grown me professionally. So honored to be a part of this group. Thank you.
This is Katie Adams. I'm the CEO of Southwestern Behavioral Health Care.
And then I think, Lindsay, you might be the only one left to introduce yourself.
Hi, I'm Lindsay Baywell. I am a policy developer with the coverage and benefits team at the Office of Medicaid Policy and Planning.
Great, thank you. So I guess we'll kind of talk about the agenda here a little bit. I should probably make a disclaimer that as a meeting facilitator, generally speaking, my approach is that, we'll, even though we have 2 hours set aside, that we'll kind of get through what we have to within the time that's necessary, meaning if it takes only an hour, not longer than 2, but if it takes an hour and that's all we need, then that's all we need. A lot of, I think, what we have to get to in terms of coming up with recommendations really requires a lot more of outside meeting work to pull kind of some information together and for us all to contribute to that. So we'll try to be really effective in, the use of our time here. In terms of what we're trying to basically kind of achieve, I think today is, the last meeting that we had, Rachel was able to facilitate and have us start to think about a lot of, initial ideas. And so what I'm going to try to do today, and really I'm going to present a framework, but really it's for all of you to say, hey, what maybe works better than that? I'm hoping it kind of just gets our juices flowing a little bit. I want to kind of come up with what might be a final framework that we're going to try to approach coming up with recommendations for. And then we had talked last time briefly about if there are people that we want to outreach that should be a part of this particular subcommittee. And I think we just have to come up with what is that list so that myself and Katie and Jocelyn can start to outreach those people to get them involved and to get their input. And then the third thing is just going back and kind of reorganizing ourselves around what's the timeline for recommendations. I'm hoping that Katie's a good complement to this, but I am much more of a task-focused individual. So, I'm going to be very focused on the fact that I want to get to, some basic recommendations under the timeline that we have to get back to the larger group. And, so I'm hoping Katie is good at kind of the facilitation of process process if there's kind of more discussion. I'm sure there's a lot of people on this phone that are really good at that. But what I will contribute and be good at really is keeping us on track and getting us to the outcome that we're supposed to achieve. So on that note, Jocelyn, do we want to share the PowerPoint that?
Yes, I just stopped sharing and I'm about to pull that up.
Okay.
One moment.
Okay, fantastic. Thanks, Jocelyn. And we can jump ahead to the framework for recommendations. So I'm just going to kind of briefly put out some thoughts that I was kind of thinking about based upon the last conversations that Katie and I had with Jay and Rachel when talking about this co-chair approach. And I'm going to put it out there with some examples. And really I'll pause myself at the end of these slides to start getting some feedback on some of these things with an idea of, how do we want to think about this framework? So when I'm thinking about, how do we look through recommendations, right? I mean, that's such a broad arena. And so I kind of laid out what I think is some of the areas that are categories, right? That we might think about what our workforce development recommendations, what do they fall under? The first one that I put is build. And in my head, build is, what you're trying to do in developing a pipeline longer term of behavioral health clinicians for the future, right? They are not going to necessarily meet your need today. And I put examples on each one of these. These are things that were happening in my head, but I think you guys will each have, a lot of, probably much better ideas. But what I've also picked up in other conversations with groups that are talking about this. So like build, I think in this committee and then some other ones, I've heard the concept of starting early with school exposures, camps, experiential learning, youth apprentice programs. Then there's this concept of, recruit, which is a more immediate issue, right? You know what I mean? And you're going to have some limitations based upon your number of workforce, but things that come up in my head as I'm thinking about recruit are, wage and benefits markets, rate studies, what makes Indiana attractive if we're talking about, because we now have this telehealth capacity. What's the compelling mission? I think there are several people on this meeting who have really focused in on how to sell the mission of what we do, which is always a kind of a pull factor for behavioral health. A third factor is, retention. This is something that Katie brought up at the last meeting, being particularly concerned about, so the people who are in our field, and keep in mind, again, we're talking right about the broad field. I have to remind myself about that continuously is, what are the things and the factors that we have to consider in retention? Of course, I've just put examples, developmental pathways. In physician work, there was a Christine Sinsky focused and started writing on joy in work for physicians in order to enhance retention and well-being for physicians in their work. That's what I put in there. I put survey down there because, to me, I think when you're talking about retention, I don't know, are there ways that we can possibly think about larger scale studies of licensed clinicians or certified professionals that speak to what they think, right, are the most, would keep them in the field, right? What are the things that are most important to them? Another concept I have, is reduce. So you're not only building, recruiting, retaining, you're thinking about for workforce, which may come back to retention, reducing administrative burden, waste in system, ineffective programs that reduce staff optimization. So one thing we're not really great at is, we always add to behavioral health, but we're not really great at saying when it is that we need to close down something, right? You know what I mean? And so when everybody's spread thinly across programs and some of those programs only being partially needed, it can, have an impact on workforce. Qualify. This is something that I think I heard Steve and Matt Brooks at the last meeting talking about, which is things like certification and licensure. How are we adding to the pool of people that can help in our behavioral health initiatives? That could include MAs, LPNs, RNs. And so there's this piece about, how we qualify. And again, I think at the time, last meeting, it was connected to this idea of two, right? That reimbursement follows licensure. Then there's expand, and expand is different to me than build. I mean, it's thinking about when we're talking about the workforce, not just the treatment workforce, but, it might be the prevention workforce, right? And that might be connected to another subcommittee. But if we're talking about having, when everybody funnels up, right, and needs to access only one type or a couple types of practitioners, instead of thinking about how we, dealt with prevention, well, I feel like you could potentially be just in a vicious cycle with workforce. Scope of practice. I think that was something that Katrina brought up. So scope of practice, training and competencies, what should people, if I was thinking about substance use and recovery, right? Not every behavioral health clinician who becomes licensed, necessarily has the credentials to provide substance use, or even in continuing education, don't necessarily get themselves involved, right, in that. So there's, things that could be thought about maybe from that perspective. Optimization is then one, two, which is your workforce efficiencies, your capacity, your leveraging of technologies. And I put in there next to capacity, and why I, at least in my head, we could take all of this off and reduce this down to three things or one thing, folks. But I put capacity in there because what we're regularly talking about is how we bring new clinicians to the mix, which is important. But what we probably, I guess in my mind, need to equally prioritize is how we optimize the capacity within reason that we have today. And so things like scheduling, how people schedule, make a big difference. And actually what sometimes I think is surprising is that most behavioral health clinicians and managers don't really have an idea on how to effectively schedule to maximize no-shows, reschedules, et cetera. Primary care has been doing and trying to manage this for years. Behavioral health care is a little bit further behind the 8 ball on this. And then length of episodes, right? So behavioral health clinicians as a group generally aren't, a big portion of our training is not on how to terminate a therapeutic relationship, right? So what happens is if you were to examine length of episodes of care, right, you could have somebody who has been in treatment for a very long period of time, right, with parity expectations and rolling authorizations. They could be in care continuously. But the question becomes, when is that care note? When does that clinician, whatever form they are, need to be able to say, I think we've kind of met our max here, right? Or, and if you think about general therapeutic effectiveness, if you've got the right schedule of sessions, effectiveness goes up over 20 sessions, and then actually after 20 sessions starts to go down again, right? So that's just a piece, I think, when we're talking about optimizing workforce, that when people are in care and they're in care too long, right? You know what I mean? And again, that comes back to those outcomes, but I think that also comes back to length of episodes. So these are the kinds of things that what I was thinking of, and I was not sure, what everybody thought here is in every little thing. So build, recruit, retain, reduce, qualify, expand, optimize. If diversion, inclusion, and equity is weaved into every single one of these, right? So that when we're thinking about recommendations, that that kind of lays over each one of these components. So I'm going to stop there. I wouldn't mind getting some, feedback from folks on, these categories. If it's too many, we think we need to just focus in on a couple of them, or maybe is there a better way to organize this, or am I missing something? So I'm going to turn this over to the group.
I'll just have a quick reaction, Carrie. I think this is great. I don't think there's a right or wrong way to organize it. You could organize it differently, of course, but I think this captures in kind of a thoughtful way a lot of the things we want to focus on. And I would just say real quickly, you mentioned reimbursement, and we did talk about that last time. And I don't know if I'm seeing it. So I would just throw out that somewhere we probably need to specifically talk about reimbursement. And then that also connects to, at least for me, and I think for others, is credentialing. Credentialing is a barrier that prevents reimbursement. And so those would be my 2 tweaks to your thoughts.
I think both of those fit nicely under recruiting, because credentialing is a part of the end of recruiting, right? And reimbursements connected to the wage and benefits. But I really like this as well. I think for the purposes of our timeline, we're probably going to need to decide what we think are the well, the low-hanging fruit, but also what do we think is the place to start? Because that's a lot there.
You know, it is a lot. And the one thing I was thinking about, Jocelyn, can we jump forward? Might have to jump forward to, it might even be 2 slides.
That's all you for.
Yeah, no, that the last one. Yeah, that's the one that
Okay.
I want to pull up real quick. Sorry.
That's okay.
So, you know, I think that's one of the things too that I wondered about in discussing today is there is this piece of, again, identifying exactly what you're talking about, the now, near term, and long term, right? And I would agree with, first off, let me go back, that with the reimbursement and credentialing, that does absolutely, you know what I mean, have to fit into this picture. But there's this kind of tension, right? That point that I feel, which is we could talk about now, near term, or long term, okay? But the challenge we have to me is what's critical versus areas for future exploration. Because so we could get, I have a little concern as to if we could hit low hanging fruit, I think that's really great, okay? But if we focus in on something that we can kind of, hey, something we can do today, and we don't really call out, here are the most critical recommendations, right, in our opinion, that have to be started today, right? This is of an urgent nature in order to be able to hit many of these things, right, and be prepared in the long term. So something that might take longer to get approval still might be urgent enough that it needs to be started, right, today. That what we don't want to say is, hey, we'll approve these 5 things as recommendations because they're easy to approve and, you know, they'll start the ball and everybody feels good, okay, because we're doing something, compared to really saying, hey, listen, here are some critical, you know, pieces. And if we don't start addressing these now, right, you know what I mean? So example, I think the one that's going to come up, which is to your point, Steve, over and over and over, and it's the most complicated, is the rate piece, right? You know what I mean? In reimbursement. And yet, you know, so, you know, things like doing rate studies though, right, can be done and started more immediately, right? To start to say, hey, there needs to be a process to really undertake an assessment of, you know, very specific rates. I mean, I look at, and I don't know what they did, and maybe somebody else on the call does, but, you know, I look at beads, I think it was beads, that, you know, they really got a rate reimbursement increase as of recent, right? And so what happened is then I can say in our local area, the rate to hire went from roughly about $12 to $13 an hour to those providers who service intellectual and developmental delays now being able to pay literally today in the same market that I'm competing in, $16 to $17 an hour for a direct support professional, right? So when you think about it, and so what did they all say when we've asked them about it? They have applicants coming in hand over fist, right, in ways that they've never had before. So I don't want to get caught up in just the rate piece. There's a larger picture to this, but I think that there are pieces here that's a longer term need, but to not say that it's the most critical and we need to be calling it out early in the process, right, could be, you know, something we need to. So I don't know how people feel about that critical, you know, how does the critical and urgent needs fit into that picture?
I think you're right. And of course, when there's so much to do, it's hard to know where to start and where to focus. And again, I'm not sure we can be wrong just because there is so much that we need to do. on the rate, I just wanted to clarify, for me, reimbursement means what you said, the rate, but it also means what is reimbursed or who is reimbursed. And it seems to me those are two different things. And then the other thing I thought of as you were talking, and I don't know if it was on your list, and maybe it fits in one of the categories, but I think we ought to make sure that we say it, and that's telehealth. Telehealth is really important to workforce, but it is only important for those who can actually use it and be reimbursed by it. And then that goes to scope of practice. And so, I mean, it's kind of interesting, you know, can you get reimbursed for it, and can you even do it, you know, as a scope of practice? So seems to me those are all intertwined, but all really important for the future.
Two other things I wanted to tag on to what Steve said under the recruit would be reciprocity. I know legislation was done a couple years ago regarding improving reciprocity from other states, but that continues to be an issue for us when we are trying to recruit, because we've been expanding that more because there really isn't anyone to recruit in Indiana. So reciprocity, I would like to re-engage conversation on that and revisit that from a credentialing standpoint and making that more smooth. And then another thing that was done legislatively that has not been refunded that had a pretty good impact, and I think is something we could address if we couldn't get rates or we couldn't get that right away, would be loan forgiveness. And that was done back, Rick, you probably remember that date, but it was done, I want to say maybe 5 or 6 years ago, and that has not been refunded. And so we've not been able to use that, and HRSA changes their standards on a federal level. So that's a very difficult process. So if we could do something as a state to address loan forgiveness, I think that would be enticing for people to get into the field.
I wanted to just kind of think about recruitment from a strategies perspective and how do we diversify this workforce. First, we have to get the word out. So I think that there's a public education campaign that has to happen. People do not understand what we do. They don't understand the different certifications and what they can and they can't do. And I think if we make it public knowledge, we're talking now more about mental health than we have in my lifetime. We're seeing commercials that mental health is health, and starting to destigmatize, if you will, but we're not talking about the people who provide the care. And I think there's a lot of opportunity for us to make a recommendation on a public education campaign, just like we did with Know the O and Know the Facts, and really making this widespread understanding of what you can do in this field. I mean, most people, lay people, know what a nurse does. They don't really understand what an LMFT does, or they don't understand what an LCSW can do in their scope. So I think that there's an opportunity for us to publicly educate that will help in our recruitment, along with things like loan forgiveness. And I also think that there is a huge opportunity for us to do some fair hiring practices, you know, kind of ban the box thing. People with lived experience also come with past. And I think that's been a barrier for a lot of folks that we need to address as a state too, that if you've paid your debt to society and you've maintained sobriety and you have this great lived experience, and then you obtain an education, but you're still facing barriers in the entering the workforce because of your criminal history, we're doing a disservice to some of the greatest providers ever.
So did anybody else have anything that they want to add? All of these things are just phenomenal ideas, and we're writing them, you know, all down. I cannot see if somebody has raised their hand, so you just have to kind of, you know, jump in there in order to.
Okay, sorry. Yeah, I raised my hand. That was yeah, that's good to know. I just wanted to touch on what Steve was saying about telehealth, because that's really something that we've been getting into on the OMPP side of understanding the scope of licensure of who can or can't provide telehealth services, how it's written currently in Senate Enrolled Act 3. It's very specific on which practitioners can practice telehealth. So, we're trying to get some clarity on that from like IPLA and how they're planning to implement that bill to understand which providers can or can't be reimbursed for telehealth services. But obviously, we're leaning more towards, the possibility is that it can be an expanded list and that a practitioner doesn't necessarily have to be licensed in order to provide the service. That would be what we would hope for. So just wanted to say that was something that we are also on the Medicaid side really want to understand and expand as well.
All right, thank you, Lindsay. I don't know, I could not hear you very well, Lindsay. I just want to make sure, am I the only person?
She was kind of cutting in and out.
Yeah. Sorry, I'll put it in the chat.
A little interference or something.
Okay, I think she said she's going to put it in the chat.
Yeah, I think she was saying, and if she wasn't, then I'm going to say, I think it's important that we expand telehealth beyond licensed professionals. And, if we have somebody that you can get if somebody's certified and Medicaid reimbursable in person, it makes no sense to me that you can't do telehealth with that person. And that's just limiting on the workforce. It's limiting as it relates to peers and recovery coaches and all the people that we want to increase utilization for. And so if you're a provider and you're hiring recovery coaches and they can see people in person, but they can't do anything through telehealth, that makes no sense. So I don't know if that's what she was saying, but whether she was or she wasn't, I'd like to put it on the table.
It's in the chat there.
I can read that from her. That's okay. So sorry, just wanted to say that OMPP is seeking clarity from IPLA in regards to which practitioners can provide or get reimbursed for telehealth. Currently in SEA 3, only licensed behavioral health professionals can provide this service. Also from Katrina, New York and New Jersey have utilized funds to pay for training and certification of SUD professionals, which have proven effective in their workforce recruitment efforts. They are also reimbursed by Medicaid in their states.
So this is just, if I could just talk out loud or think out loud here for a minute. This is like a really overwhelming task. There are like so many things that we could talk about and all of them are equally important. But when I think about things and kind of okay, what goes first kind of thing, what I'm hearing is like two buckets of ideas. One is like, okay, we need to get people. We need to get rid of the barriers it is to recruit people. We need to get people in our field. We need to be able to hire people. And then the other bucket is once we have these people, we need for these people to be able to do their jobs and get reimbursed at a rate that makes sense, right? and have this, be able to hire people to do the work. So when I think about the first step, which is we need people, I love what Katrina said about, people don't know what we do, right? But they know based on the movies what we do. And we need to remove barriers on who we can hire, because there's these peers out here, there's this group of people we're not able to access. We need to be able to hire people at a competitive wage. So I think that's a big piece. And then we need to also be able to keep the people we have by paying them a competitive wage and making their jobs, mission focused. So I kind of think that's like, to me in my brain, when I think about all these things, they're all equally important. But Carrie, I think you're right. When it comes down to the big thing is really just reimbursement rates is kind of the big thing that we need to say is one of the big future targets, right? And then how do we recruit? All of us are struggling with recruiting. So how do we get our field out there?
Yeah, I would agree with all of those things. And I will make a plug for too, that, if we're talking about, to Zoe's point, there's only so many practitioners. And actually, I think somebody else made this, that it's we're just moving the same pot around, right? All the time, right? You know what I mean? They might try different things, but it's the same. Is, you know, if we have to think about what our near-term strategies though too, I think this is kind of where some of that telehealth comes in. And others, is I do think we have to think about how we move our system towards optimization. Okay. And, you know, and this might not be tackled completely within the framework of these recommendations, but, you know, I feel pretty strongly about these things. I think we have to be willing to challenge what I'll call sacred cows, right? And that means also so like a sacred cow to me is this idea that you have to see somebody for 45 minutes to make effectiveness. I know, and again, I could be off, I know of no such research that says that time in session to being the most critical feature to outcome, right? But in some ways, if we're trying to build a workforce and we're also trying to optimize, we have to be willing to train actually, and I'm not just saying therapists, I mean everybody, right? In what it means to be effective, not just from an evidence-based practice standpoint. Okay, so we can have a model, you know, and everybody can use all sorts of different curriculum, but to be, you know, optimally effective just from an evidence-based practice approach, you know, I think that that's a big thing, because what we don't do enough is think about when you have 10 clinicians of any type, right, how are they most effectively used, deployed, resource allocated, and optimized? And so nobody wants to talk about people in that fashion. I totally understand that. But when we have a growing problem, we have a escalating number of individuals who need assistance, you know, we have to be willing, I think, within our disciplines to go back and say, just because we've done this way for so long, is it absolutely necessary to continue to do it this way, right? So, and can we change the way, you know what I mean? I practiced in integrated care, right? You know what I mean? So I know that having 15 to 20 minute, you know, interventions with people, right, over a period of time can be useful, helpful, and have really solid outcomes. And it didn't take me 20 sessions at 45 minutes a clip to make that difference, right? And, you know, but again, depending on how you're trained in school, so this takes us back, again, maybe longer term strategy, but depending on how the workforce is trained in models when they're going for certification, training, education, also then impacts how effective they are, the models they use, and how well we achieve capacity with our workforce today. So I agree with everything that everybody's saying. All these things are so unbelievably important. The thing that I'll probably continue to make a plug at is this optimization piece, okay? Because I think that if we don't think optimization, we will not effectively leverage the workforce we have today, and we're not going to have all sorts of people that just come flooding in tomorrow.
Yeah, and Carrie, I don't know if you're familiar with the research, and I could be totally misquoting this, but I think it's something like 70% of somebody's outcomes are directly related to social determinants of health, and then the other 30 is related to the actual intervention. I don't know if I got the numbers right, but it's something like that. Is anybody familiar with that? Maybe not. But it just speaks to what you're saying, Carrie, is just, you know, blowing up this idea of what a clinic is supposed to run like. I'm supposed to have these 8, 9, 10, 11, 1, 2, 3, 4 appointments, and increasing the use of treatment teams, right? Not everybody needs a therapist. Some people just need a skill coach or a peer.
Well, and it may go back even to how, if for saying that, you know, again, those prevention needs, right, and social determinants of health, and, you know, equity issues, all of those things factor into, right, somebody's outcome, then it certainly suggests that, you know, should there be consideration for, you know, that the most effective use of a behavioral health wide workforce, right, is not always just the piece about adding more clinicians. We do need that, but it's where you put the money too, right? You know what I mean? And, you know, I mean, I think about how many times have we all listened, you know, to the story. I think I was even in a meeting with FSA talking about, you know, when people, you know, catching people upstream, right? You know what I mean? So that, you know, because we're never going to add probably enough behavioral health clinicians in the space to manage all of the issues, right, that could arise potentially, particularly now over these next few years. we may be able to effectively start to prevent, right? You know what I mean? As much as we can, and then address those SDOH issues. I think about things like, in lieu of services, right, for Medicaid, managed Medicaid, and what can be used there to address social determinants of health. So I think there's a lot of probably creative ways, but to your point, what are the biggest factors? And workforce effectiveness is achieved even by prevention efforts, to me, right?
Mhm.
One thing I wanted to add, going back to the conversation regarding reimbursement and then also a campaign, is that as we have states on our heels changing their payment structure model to align with CCBHC, I know Illinois, Michigan are very close to that. Kansas passed legislation on that we are going to have a greater impact on a regional level with workforce. And so I think going back to what Katrina said, as far as doing a campaign and the benefits of Indiana, we used to strike a lot in Illinois because everyone wanted to get out of there. And so now's the time before all of that gets into place, because then if we don't change our structure, which might take a little bit more time because I think they're further ahead, that we could be at a greater loss on a regional level.
You bring up a good point about CCBHC. The timing is really interesting because the one thing that's been easier for us to hire are the positions related to our grant, because everybody's super excited about this new thing. We're going to treat everyone, everywhere, anytime, we're going to go save the world. So we have this big mission as a CCBHC. And if the state came to a place to be a CCBHC state where we're funded differently, there's your mission focused recruitment, right? So the timing with doing a PSA and CCBHC is really good right now. People are pumped. And Congress has all the, they're spitting out stuff all the time. The National Council is about how effective this is.
Anybody else have thoughts to add? Or I think we'll kind of jump to the next segment of decision making for today.
Carrie, I'll just add a quick thing. I was looking at the Bowen Center for research, looking for a more current study of licensed professionals in Indiana, and it kind of gives the age breakdown from the one in 2016. We should be due for one coming out for 2020. We might want to get a copy of that as soon as it comes out and have that available, because one of the things that always shocked me was the average age of all the licensed professionals, which was closer to retirement than to the mid point of what you expect it to be. And we've got to change and get people going into the workforce, not just, like you were talking earlier, recirculating people within the same pool of employees. And it doesn't seem like, at least from 2016, that I don't know if that's been impacted yet or not.
Okay.
Rick, I think you can tie psychiatrists to that as well if you look at the average age.
I'm talking also all professionals, social workers, psychologists, and psychiatrists and nurse practitioners.
No, I agree with that. So the problem's going to get worse before it gets better. And that study was done at a time, and I'm not saying that I agree with the premise, but that study was done at a time when politically there was discussion about eliminating or minimizing licensed professionals, and because it was seen as barriers. And so while I don't agree with that, some of their concepts do ring true, that we do put a lot of barriers in front of the workforce that continues to shrink. And we need to come up, as we're all saying, we need to come up with a way to make the pie bigger. We're not going to be able to recruit our way out of this. And if we want to educate, that's a good idea, but that's a long-term solution. We really need to figure out how to broaden the workforce now.
The other thing is we're getting beat up by states that are paying higher rates than we are for employees. And when I went to MHCA, I would hear people talking about how they're advertising in Indiana to pull people out of the state to go to Colorado and other states where reimbursement rates were much higher and they could afford to pay more, and therefore people chose to leave for a greater salary. And we've done nothing to rates to improve that situation. We've just made it worse by not doing anything.
I think you'll see a correlation in the states that have legalized marijuana as well, because they have that greater tax revenue.
Mm. In terms of, Katrina, you're saying they've been able to play more with essentially their rates at that point.
Absolutely, because they're generating more tax revenue from the legalization, whether recreational or medicinal.
Mm-hmm.
I mean, I get offers from Colorado all the time, and it's unbelievable. I always wonder how I get all these mailings from Colorado and the rates that they're offering. And then, of course, you look at the cost of living and do that comparison. But frequently I get advertisements from Colorado and from Michigan, which are both marijuana legal states. But I don't get them from Ohio, which is 10 minutes from my house.
All right. Well, on this note, so part of what I'm observing between the last meeting and this meeting, right, is that we have a bunch of different and great ideas. And so I ran one of these, or facilitated one of these type of subcommittees for the Committee on Improving the Status of Children. And part of the approach we took at that time to get down to some basic recommendations, and I'm happy to share that document to kind of see what that looked like, is, everybody who was on the committee. Well, first off, we identified who else that we needed on here, right, that weren't. But then number two, everybody had to document and send in, right, not just from these meetings, kind of here are the things. And it could be you could use the bucket areas that we've all talked about as kind of a guiding, framework for thinking about this. You could put recommendations under each one of them, or only two, like Katie was saying, did they just fall into two buckets? But really, part of this is everybody's got to write down, right, what their recommendations are. They need to submit them. And then we need to be able to take those, put them together, and then for each of us to go through as a group and say, is this something that we feel, right? You know what I mean? Is something we can turn into a very specific type of recommendation, right? And then we can vote and we can potentially approve those. And I think, while it seems like a very large endeavor, I think it's possible, even given from the last time to this time, we're hearing similar themes, I feel like, right? You know what I mean? So I think it's possible for us to come up with, even if it ends up being 5 or 6 different things, you know what I mean, or 7 or 8. And that's kind of the approach that I'm hoping to take, right? So we can do that in a SurveyMonkey format, right? That allows everybody to contribute. It allows us to get input even from a wider audience, should we want to do that. And then that way that data can come back, right? We can bring that back to the committee and say, hey, let's look through this. Let's talk about it. Let's get this to the recommendation, or take it off, right, the list, something that, maybe in the future for consideration, but not one of our recommendations. That's kind of how I'm thinking that, to approach it, so that we don't have all of these great minutes that have all of these great ideas, but it never lands its way. We lose track of them, right, over time. I want to kind of keep them in one succinct area for us to kind of vet out. What are people's thoughts on that approach?
So Carrie, I don't know if you're saying this or not. So I like your idea. The only thing that I would suggest, as in remembering that, legislation created the Behavioral Health Commission, and this is going to go to the commission for the long-term plan in the future. I would like to keep develop the list, prioritize it, either based on short-term, long-term, critical versus not as critical. But I would hate to eliminate recommendations that we all think are important, because the commission hopefully will be developing a long-term strategy, and I'd hate to cut things off the list when we might want them to be there, even though we won't get to them for another year or two.
Yeah, that makes sense.
Carrie, I would just kind of echo what Steve was saying, and I like the format and I like the use of the Survey Monkey because I think that can quickly gather the information and the thoughts and give us some priorities. But also we don't want to lose course of some of the other things that could come in the future from our discussions.
I would agree.
There's a
Carrie, is
question
there-
in the chat regarding the deadline for this plan and the timeline. I just wanted to make sure everyone was aware.
Yeah, and I was just going to ask, do we already have another meeting scheduled? I don't recall.
I don't think so. I don't think we do right now, but we'll end up following up. But that, so if we can jump to the deadline and timeline, and because I could not remember it, I'm getting myself a little confused these days with the 988 work group. So, you know, is this, and I don't know if Jocelyn or Rachel, if you might be able to jump in here. You want recommendations from this committee, ideally by when?
So it would be ideal, probably in the next month or so. That way, that'll give us time to compile all of the recommendations from all the different subgroups, kind of synthesize them, make sure there's not duplication in time for the October deadline.
Mhm.
Okay.
So a concern that I have is, you know, I'm also on the continuity of care. Actually, Carrie's on that with me too. It was really difficult getting a meeting scheduled. And so with a short timeline, it might be hard to get another meeting scheduled. So I'm wondering if there's a way we can do this through survey. I like the Survey Monkey idea, but is there a way to not have to schedule another meeting and come up with this electronically?
Yeah, you know, Katie, I'll add to that. So the group that I ran for the integration subcommittee for CISC, we rarely met.
Okay,
We
good.
did everything through email. Everybody got assigned, right? Here's the homework. Here's what you have to fill out. You know, here's what we have to vet. Please send your feedback by, you know what I mean, this date, even on the recommendations. So it's possible that if we could get off the meeting today and, you know, and then really we work to establish what those questions are, right? That'll be very targeted, focused, that we could get a Survey Monkey out, right, to all of the subcommittee members. If we could identify who we also want to participate, right, even if it's not a face-to-face meeting, and, you know, everybody kind of sends in like, hey, I think this person, right, from, I don't know, it could be from private practice, right? Like I'm thinking of areas that are not community mental health that we need to incorporate into this, right? Here are some other folks on the peer end. Here are some folks from IPLA, or, you know, or if there's somebody, you know, that we feel like we need to pull in from higher ed. I mean, I'm just kind of spoofing off the top of my head here, but, you know, we can include them in that, right? So that those questions can be identified, approved by the group, Survey Monkey sent out, all within, right, probably, you know, a week to a week and a half period of time, providing, you know, providing people a very limited window, reasonable window, but still limited, right, to provide their feedback. All of us know we're going to fill that out pretty quickly, right? Then we pull all that together. We may need, and everybody takes a look at it, right? And we start to prioritize it. It may literally be that we only need one meeting to sit through, right? And, you know, talk about the prioritization, or we work through that all through email and electronic communication. And then we come together for official review of the final document, and including, you know, approval of it to go to the larger BHC. So I don't think we have to do a lot of meeting, frankly. And I think meeting is, you know, we can talk about this stuff a lot and we can process it, but I think we need to be action oriented, is my 2 cents.
So just a point of clarity. So this group is addressing mental health workforce across the board, not just within the community mental health centers like Jocelyn represents at DMHA and some of us through our centers. So the local group that I chair on workforce development for mental health, they could provide a lot of feedback on that Survey Monkey
Yes.
Okay.
Yes. Yes. And really, Zoe, if you had folks that, were larger, I mean, again, the group has to define this, but, if we had folks that we could identify that have pretty large, sustainable, maybe even multi-specialty practices, group practices, right, that contribute to that. Then, and two, right, peer groups, whatever. So yes, absolutely, because the BHC's focus is not community mental health. We're one piece of the puzzle, but it's to address the totality of behavioral health needs, and in our case, workforce needs across the board.
For
So-
clarification, maybe Rachel can answer this. After the recommendations are provided mid-August, is this subgroup done, or are we anticipating this group coming together to fine tune things later?
My thought would be that we will, after we make the recommendations, we will kind of evaluate where things line up, where there's duplication, and kind of look at the work groups and see if there's any that make sense to merge. I would imagine for this particular subgroup that we would keep working on it, because kind of the vision is we make recommendations to the council, then that gets, I guess I'm kind of describing our dream world, right? Then whatever our recommendations are, a few of those items get some traction, and then we start figuring out how to go about implementing them. And that could be outsourced, of course, to an organization that's already doing the work and doing it well, that we want to maybe petition the state to allocate some funds toward. It could look a number of different ways, but my guess is that we won't get it perfect 100% our first go, and then from there it'll take a little tweaking and a little hopefully discussion about implementation. Does that answer your question?
Yeah,
And
I think that's helpful, because part of this is the
Yeah.
scope of what our task is.
Yes.
And so it just, I think that's helpful to know, so we don't get too far into the weeds.
Mhm.
And get, and not accomplish what we need to accomplish. So I think that's helpful to know.
And I think with recommendations, I think what's important to know is I think, and this is something that I've struggled with just in my transition to the state, to know that there are recommendations we don't necessarily have to actually implement ourselves as the boots on the ground, that we can make recommendations around having a consultant come in and do an evaluation and make more formal recommendations. We can make recommendations around, I don't know, loan forgiveness or collaboration with XYZ universities. We can do kind of some of those things and maybe say that there's a person at the state that would be responsible for this. I think where it will become, challenging is figuring out where the funding will come from. But I understand that mental health will continue to be a focus of the governor's office. So I'm hopeful that if we are able to come up with some, a small but mighty menu of recommendations, that we'll be able to pick and choose from some of those and get some things moving.
I guess in going to that question about funding, when we're looking at these things, is there already, as part of the COVID relief funds and a part of the $100 million that the state gave us in legislation, is any of this earmarked for workforce development at all, to kind of help us know what we're working with?
We are still kind of working out the details of all of the funding. We're fortunate to have a pretty big amount of funding dumped in our lap, so it's a good problem to have. But we are planning to dedicate some of it to workforce. We're still ironing out exactly what that is going to look like. So I think once we have more information around that, we can, I think the sooner that we get recommendations from this group, the more that we can look at how we specifically tailor that funding, and or do we reallocate or allocate some funding differently toward this initiative.
Rachel, is there a timeline when that's going to become public?
I would say probably, my guess is, so all of this, as you can imagine, we have 1 million layers of approvals that we have to go through, and any hiccups in any of these layers can kind of cause us to go back to the starting block. My hope would be within the next, I'm just gonna kind of try to under promise and over deliver, would maybe be in the next 4 to 8 weeks. But I don't know that for sure.
One of the things I was really impressed with, and I think Lindsay's still on the call, is FSSA sent and HCBS sent out a very well thought out strategic plan of what they're going to be doing with the current funding that was allocated. And so I would really encourage DMHA and FSSA to maybe do that same for mental health. How they addressed workforce in that plan was the first time I really have seen the state put an intentful focus on workforce. And so if there's a way that we could also provide that education statewide, I think that would be really helpful.
That's great, thank you.
All right, so we've got till, it sounds like, basically maybe mid to, I'm hoping at least towards the later part of August, to get some recommendations organized. So is everybody then good with the Survey Monkey approach? We'll probably look to schedule maybe one more meeting, but the goal will be that is set such that, you know, we've been able to kind of between us all electronically sort out, gathering the information, you know, vetting out, you know, the list of recommendations, and then working to turn that into actual recommendations, just not an idea, right? Something that's tangible. I personally feel like it is very doable because this is basically about the same amount of timeline that we had to start to get the CISC subcommittee recommendations together. It's just a matter of, you know, we're going to be doing, and about the same time, honestly, it was over the summer. So that's always tricky because people are out, but is everybody okay with the approach that we're going to take to try to knock some of this out over the next 4 or so weeks?
I'm good.
Okay.
Good plan.
All right. Okay. And so then on that note, what the follow-up will be is I will get with Katie and Jocelyn, and we'll try to come up with some generic kind of questions here. I shouldn't say generic, but some sense of a survey question. If there's anybody on here who would like to participate in the development of those survey questions, can you please just let me know now, put it in the chat, or, you know, shoot me an email, because we'll probably round about those questions and we'll send them out very quickly to then the entire subcommittee, you know, just to say, hey, get some quick feedback on them before putting them into the Survey Monkey. So is there anybody who really wants to be a part of that initial discussion on just the framework of questions? And don't all jump up at once.
I'll help you, Carrie.
Okay, thanks, Katie. All right.
We'll
All right.
get it
I feel like Katie and I are stuck together at the hip a
We
little bit here
are.
for a
We'll
couple
figure it
reasons.
out.
Okay, the second thing is there anybody who, so like Zoe was mentioning, she can connect with that local workforce group. Is there anybody that you feel like you want to include as a part of this subcommittee in kind of this review over the next and Survey Monkey data collection, but then also helping vet the ultimate recommendation? So is there anybody that we're missing that by the end of this week that Katie, I, Jocelyn need to contact and see if they want to participate so that we get them involved immediately? If not, we can always just have multiple people fill out the Survey Monkey. I just need to clarify if we're missing any subcommittee members that we want to make sure we add immediately.
Carrie, the only thing I can think of, and I believe you all touched on this earlier, is yeah, I think a big part of the strategy is establishing a baseline. And so thinking about who might be the best partner, you know, to help us establish that baseline, because the problem is, as you all know, that it's a little bit fragmented in that, you know, IPLA has licensed folks, but that doesn't necessarily represent our bachelor's level individuals at this point. You know, same kind of situation with Medicaid, that Medicaid tracks are people that are registered as providers in the system, but if they're not the rendering provider, they're not registered with Medicaid. So I don't know about maybe the Indiana Chamber, or someone that has someone maybe with the NASW. I apologize for not having more specific recommendations, but I think that would be worth either not necessarily engaging for our next. One of the recommendations could be establish a baseline, but I think that is something to kind of make sure that we have on the forefront.
So I wonder if that, Rachel, could be done through associations, because just about everybody, whether licensed or not or credentialed, have some kind of a group in the state that they're connected to. And I kind of wonder if that we might be able to funnel a lot of that through not just the chamber, I think is good, but through various associations that exist.
The only people that I feel like we might be missing with this idea of how do we kind of grow our own internal workforce with creating a pathway for our kind of direct service professionals to, if for whomever's appropriate, becoming a fully licensed clinician, where the people that we would miss would likely be those associates or bachelor's level folks, unless there's an association that I'm not familiar with, which is definitely possible.
Do we need some like an Ivy Tech representative or a higher ed?
I think that would be.
I just put that in the chat. I think the association ideas are really good. The hospital association as well. I mean, we have a lot of community mental health center individuals here, but we're leaving out a whole sector of the hospital associations that employ a lot of behavioral health workforce. The Rural Health Association and higher education, I think, need to have a voice because they can offer us a great deal of feedback that we may be missing.
And
Steve,
also,
go ahead.
Workforce development. I know, Carrie, we've done some work up in our region with Roger and Feldhouse and the grant that he was working on, but that could also be a good connection.
Yeah, that's a good idea too. Okay. Okay. All right. All right. Anything else for the purpose of today's meeting? As you can probably tell, I'm going to generally be not in favor of being on the meeting for 2 hours if we can wrap up in an hour. So does anybody else have, anything else that they want to add for today? Otherwise, Katie and Jocelyn, I'm going to shoot you guys an email to find a time that the three of us can connect here in order to start laying out some of these survey questions pretty quickly and then round back to the group with some ideas here. So anything else for anybody today? Otherwise, I think we all have the marching orders.
I will get the notes together today and get them over to Jay and Rachel just in case they have anything additional, and then get them to yourself, Carrie and Katie, and then that might be a good stepping stone, I guess, for those questions, or those survey questions.
Okay, and so I see what you just put in, and so we'll include you then in those questions. Appreciate the offer to help.
Yeah, I think I just through the other local forum might be able to offer some insight outside of the community mental health.
Perfect. Okay. All
Very
right.
well run meeting. Thank you so much.
Okay. Thanks, Steve. I'm a taskmaster. No, okay. Yeah. Talk to you guys later. Enjoy. Bye-bye.
Bye.
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 You need to get down. Whoa. I know. You're going to have to do it for a second. I know. I'm sorry.